Welcome to Roadmap to Residency. Today we are diving into one of the highest yield endocrine topics on the Step 2 board exam, Pituitary Disorders. This is not a traditional lecture. We are going to walk through real board-style question stems and break down the test-taking strategies you need to crush these questions on exam day. We will cover pituitary adenomas, hypopituitarism, diabetes insipidus, and the syndrome of inappropriate antidiuretic hormone secretion. For the foundational science behind these topics, make sure you review the endocrine chapter in First Aid for Step 2 and the corresponding sections in your question bank. Now let us get started. Here are your learning objectives for today. By the end of this video, you should be able to recognize the classic question stems for pituitary adenomas, hypopituitarism, central diabetes insipidus, and the syndrome of inappropriate antidiuretic hormone secretion. We will focus on test-taking strategies that help you eliminate wrong answer choices and zero in on the correct answer. Remember, this video is designed to complement your primary study resources. Make sure you are also reviewing the endocrine sections in First Aid for Step 2, AMBOSS, and your main question bank for the complete foundational knowledge. Here is the framework that should be your first instinct every time you see a pituitary question on the boards. Ask yourself 2 questions. First, is this an anterior pituitary problem or a posterior pituitary problem? The anterior pituitary produces growth hormone, prolactin, thyroid-stimulating hormone, adrenocorticotropic hormone, and the gonadotropins. Adenomas here cause either hypersecretion of a hormone or mass effect symptoms like bitemporal hemianopia. The posterior pituitary stores and releases antidiuretic hormone and oxytocin. Problems here lead to either diabetes insipidus or the syndrome of inappropriate antidiuretic hormone secretion. Second, are you dealing with hyperfunction or hypofunction? Hypersecretion gives you galactorrhea, acromegaly features, or Cushing features. Hyposecretion gives you fatigue, cold intolerance, and adrenal insufficiency symptoms. This framework is your anchor for every pituitary question you will see. Now let us lock in the buzzwords. When you see these keyword combinations in a question stem, your brain should immediately jump to the diagnosis. For prolactinoma, think galactorrhea plus amenorrhea plus bitemporal hemianopia plus an elevated prolactin level. For acromegaly, think enlarged jaw and hands, coarsened facial features, and an elevated insulin-like growth factor 1 level. For central diabetes insipidus, think polyuria, polydipsia, dilute urine, elevated serum osmolarity, and a response to desmopressin. These buzzword clusters are tested over and over again. Commit them to memory. You can find detailed buzzword lists in the endocrine chapter of First Aid for Step 2 and in the AMBOSS library. Here is your first case. A 32-year-old woman presents with 6 months of amenorrhea and milky nipple discharge. She reports new headaches and difficulty with peripheral vision. Her exam reveals bitemporal hemianopia, and her serum prolactin level is markedly elevated. Take a moment to think about what diagnosis fits this presentation and what the best next step would be. Remember, on the boards, you want to identify the buzzwords first before jumping to the answer choices. Let us walk through this together on the next slide. Let us break this case down. The buzzwords are amenorrhea, galactorrhea, and bitemporal hemianopia. Amenorrhea plus galactorrhea immediately tells you there is prolactin excess. Bitemporal hemianopia tells you something is compressing the optic chiasm, which means this is a macroadenoma. The markedly elevated prolactin confirms a prolactinoma. Here is the key test-taking strategy. The boards love to test that prolactinomas are treated medically first with a dopamine agonist like cabergoline. This is different from most other pituitary adenomas, which often require surgery. Do not pick transsphenoidal surgery as your first answer for prolactinoma. The correct answer is to start cabergoline. Dopamine agonists both shrink the tumor and normalize the prolactin level. Surgery is only reserved for patients who fail or cannot tolerate medical therapy. Review the prolactinoma management algorithm in your board review resources for more detail. Case 2, a 30-year-old woman presents 8 weeks after a complicated delivery that involves severe postpartum hemorrhage requiring a blood transfusion. She reports profound fatigue, inability to breastfeed, cold intolerance, and absence of menstrual periods. Her exam shows hypertension, dry skin, and absent axillary hair. This is a classic board presentation. Think about what could cause all of these symptoms together after a major hemorrhagic event. Let us work through the answer on the next slide. This is a classic Sheehan Syndrome presentation, and it is tested frequently on the boards. The key trigger is postpartum hemorrhage. When the pituitary gland undergoes ischemic necrosis after massive blood loss, you lose all the anterior pituitary hormones. Failure to lactate means loss of prolactin. Fatigue and cold intolerance mean loss of thyroid-stimulating hormone. Absent menses means loss of gonadotropins. Hypotension suggests possible adrenal insufficiency from loss of adrenocorticotropic hormone. Here is your critical test-taking pearl. When you start hormone replacement in a patient with panhypopituitarism, you must start cortisol replacement first before giving thyroid hormone. If you give thyroid hormone first, you can precipitate an adrenal crisis. The boards love to test this treatment order. Review the Sheehan Syndrome section in your endocrine review materials for the complete management algorithm. These management pearls are absolute gold for the boards. First, for pituitary adenomas, remember that prolactinomas are the exception because they are treated medically first with dopamine agonists. All other symptomatic adenomas, including growth hormone-secreting tumours, non-functioning tumours with mass effect, and Cushing disease, are treated with transsphenoidal surgery as first line. Second, the hormone replacement priority order is critical. When replacing multiple hormones in panhypopituitarism, you must start with cortisol first, then add thyroid hormone, then sex hormones, and finally growth hormone. The reason cortisol comes first is that thyroid hormone increases metabolic rate and cortisol demand, so giving it without adequate cortisol replacement can precipitate an adrenal crisis. This is a favorite board question. Make sure you also know that Desmopressin is used for central diabetes insipidus. These pearls are covered extensively in your board review question banks. Case 3. A 45-year-old man develops severe thirst and is producing large volumes of very dilute urine 3 days after transsphenoidal surgery for a non-functioning pituitary adenoma. His serum sodium is elevated, his serum osmolarity is high, and his urine osmolarity is very low. After giving Desmopressin, his urine osmolarity increases significantly. Think about what is happening with water balance here and what the Desmopressin response tells you. The answer and test-taking strategy are on the next slide. Let us break down this case. The post-neurosurgery setting is a classic trigger for central diabetes insipidus because the surgery can damage the posterior pituitary or the pituitary stalk. The buzzwords are polyuria with dilute urine, hyponatremia, and elevated serum osmolality. Now here is the critical test-taking strategy. The Desmopressin challenge test differentiates central from nephrogenic diabetes insipidus. In central diabetes insipidus, the kidneys are working fine, but the pituitary is not producing enough antidiuretic hormone. When you give Desmopressin, which is synthetic antidiuretic hormone, the urine concentrates because the kidneys respond. In nephrogenic diabetes insipidus, the kidneys are resistant to antidiuretic hormone, so the urine does not concentrate even after Desmopressin. This patient responded to Desmopressin, so this is central diabetes insipidus. Treatment is Desmopressin replacement. For nephrogenic diabetes insipidus, think thiazide diuretics. This distinction is heavily tested. Review the water deprivation test algorithm in your board review resources. Case 4. A 60-year-old man with small cell lung cancer presents with confusion and lethargy. His labs show a serum sodium of 118, low serum osmolality, urine osmolality that is greater than serum osmolality, and an elevated urine sodium. He is clinically euvolemic. This is a classic board setup. Think about what diagnosis explains euvolemic hyponatremia with concentrated urine in the setting of a lung malignancy. Let us walk through it. Let us break this down. The classic diagnostic criteria for the syndrome of inappropriate antidiuretic hormone secretion are euvolemic hyponatremia, low serum osmolality, inappropriately concentrated urine with an osmolality greater than 100, and an elevated urine sodium greater than 40. Small cell lung cancer is the most commonly tested cause on the boards, so when you see lung cancer plus hyponatremia, your answer is almost always this syndrome. Other high-yield causes include central nervous system disorders, certain medications like carbamazepine and selective serotonin reuptake inhibitors, and post-surgical states. For management, the boards love to test the treatment approach. For mild cases, fluid restriction is first line. For severe symptomatic hyponatremia with seizures or coma, you need hypertonic saline, but you must correct slowly. Do not raise sodium more than 10 to 12 milliequivalents per liter in 24 hours to avoid osmotic demyelination syndrome. This correction rate is a favorite board question. Study the Hyponatremia workup algorithm in your review resources. Here is a full multiple-choice walkthrough for you. A 50-year-old man presents with progressive enlargement of his hands and jaw, a deepening voice, and excessive sweating over 2 years. He also has new-onset diabetes and hypertension. His growth hormone level is elevated and does not suppress after an oral glucose load, and brain imaging shows a pituitary mass. Read through the answer choices carefully. This is a growth hormone secreting pituitary adenoma causing acromegaly. Let us go through each answer choice on the next slide to understand why each one is right or wrong. Let us go through each answer choice. Answer A, octreotide. This is a somatostatin analog that suppresses growth hormone secretion. It is used as second-line therapy when surgery fails or when the patient is not a surgical candidate. It is not the first-line treatment. Answer B, cabergoline. This is a dopamine agonist. Remember our earlier Pearl? Dopamine agonists are first line for prolactinomas, not for growth hormone secreting adenomas. This is a classic distractor answer on the boards. Answer C, transsphenoidal surgery. This is correct. For acromegaly, caused by a growth hormone secreting adenoma, surgical removal via transsphenoidal approach is the definitive first-line treatment. Answer D, radiation therapy. This is reserved for residual or recurrent tumor after surgery or when surgery is not possible. It is not first line. Answer E, observation. Acromegaly causes serious systemic complications, including cardiovascular disease, diabetes, and increased mortality, so observation is never appropriate. The big takeaway is that prolactinoma is the only pituitary adenoma where medical therapy comes first. For everything else, surgery is the answer. Thank you so much for watching today. If this video helped you, please hit the like button and subscribe to our channel for more board review content. And if you want personalized guidance for your board preparation or residency applications, check out our expert tutors and residency advisors at roadmaptoresidency.com. Keep studying smart, and we will see you in the next video.